Today's program is called Not Your Father's CLL, and I think it's going to be very, very provocative because CLL has been traditionally a field where when John and I were training, there was just not that much to do or talk about, and it was something that it was treated as much by what you didn't do as what you did do, and thankfully that field has exploded with so many more options and better outcomes than historically we'd ever seen. So I would like to thank Dr. Pagel and our sponsors, who specifically are Infinity Pharmaceuticals, Genentech and Biogen IDEC. Just a little bit of introduction for Dr. Pagel. It's hard to do him justice. We trained together, started working together about 17 years ago, or at least 16 and a half back when we were both in our training at the Fred Hutchinson Cancer Research Program, UW SCCA program, as the SCCA was just getting off the ground. And he and I were contemporaries. I focused in solid tumors and lung cancer, and he, over the next several years, became not just a national, but truly an international leader in the field of hematologic malignancies, and has done great translational and clinical research while working there for well over a decade. Really became a very important person in the field, and meanwhile I had moved over to Swedish Cancer Institute not far away, and we were very gratified, both me personally and the institution, to find a way to bring him over to provide incredible energy for the rapidly growing hematologic malignancy program that he is the leader of there. So with that, I'm going to turn it over to Dr. Pagel to provide us some of the highlights for what we hope will be accessible, I know will be very accessible for patients, caregivers, and probably also very helpful to a lot of other oncologists like me who don't treat CLL these days very much.
Great. Okay, it's good to be here. So thanks everybody for being a little patient with being a few minutes behind on schedule. I will just say not only are Jack and I professional colleagues, but we're also personal friends. Our children went to the same elementary school, and we used to live on the same street together. So I won't share any more details about the two of us, but it's great to be here. This is a presentation where I'm trying to really provide some education for patients, obviously. And I'm going to take a little bit of a risk. I'm going to show some actual data that oncologists use or that hematologists use to actually make treatment decisions that I hope I can convey to you as important, and that might stimulate some questions and discussions as well. But the biggest thing that I want to really say is that this title is a fabulous title that I didn't come up with. I think Laura might have, or somebody, but I will say it's a great title because really what we're learning is that in CLL, the idea of using chemotherapy is becoming almost in the past tense. We're not there yet. I still use occasionally some chemotherapy in the right cases, but I know several people who are here, probably several people who are watching this, are already moved on past chemotherapy and may have a disease called chronic lymphocytic leukemia that they live with for their whole lives, but may never ever even see chemotherapy moving on. And that's a fabulous thing. And not only is it fabulous because it helps people manage side effects, do well, it also might prevent long-term issues or long-term problems that can develop with chemotherapy. And really what we're doing with these new agents and getting away from chemotherapy is really actually helping people live longer and longer. And so now, because of therapies like this, we're treating people in their 70s, 80s. Actually, I've treated several people in the last year in their 90s, where we would have never been able to treat people like that. And that's had a major benefit for them from not only controlling their disease, but quality of life. And you can imagine how important that this is. So we're going to go through this. We're going to go through some of this fairly quickly, and I hope that I'll stimulate some discussion as well. I will be a little basic at the start and mention that CLL is also sometimes known as SLL, small lymphocytic lymphoma, and this is a disease of blood cells that are essentially from the origin of the bone marrow. Now, the bone marrow is really where we make our blood cells. And we make a lot of different blood cells. You can see that we make a variety shown there, and they come in two big flavors. They're either what we call myeloid cells. Those are cells like towards the bottom there, the neutrophils, the basophils, eosinophils, or they're what we call lymphoid cells. Those are primarily what we call lymphocytes. And those cells all have a job. In general, their job is to, if you're a lymphocyte or maybe a neutrophil, but in general, they're to fight infections and to keep us healthy. So these cells are commonly born in the bone marrow. They're babies there. They grow up. They leave the home. They come out and circulate in the blood. They may find a partner. They like to live in lymph nodes very commonly. That's where their home is. And then they get a job to do. And their job is to fight an infection. Maybe that is when they become grandparents, and then those cells die. And this normal maturation process is how we actually use and develop blood cells for functions of maybe, again, fighting infections. Of course, this maturation process from a lymphocyte is important from the aspect that these cells become more mature towards generating antibodies. So that's what lymphocytes typically do. There are antibody-forming cells. And so, as I said, immature cells born in the bone marrow, we call those stem cells. Not only can they grow and make other cells, but they can make more of themselves so that our stem cells never go away. And again, we go all the way through this maturation process to a plasma cell. That mature plasma cell is what develops an antibody to fight infections. And in any one of those stages, something can go wrong. What can go wrong? Well, of course, there's some potential error in the machinery for replication and proliferation of these cells, and those cells get stuck in that specific point of their maturation. And so CLL develops in what we call a mature B cell. These are more mature cells, and in fact, in general, when cancers develop in more immature cells, they're more aggressive. When they happen in more mature cells, they become more indolent. And that's partly why CLL is known as an indolent disease. So it's a disease of mature B cells that are out in the blood, circulating in the blood or in the lymph nodes. Now, one of the problems is that people commonly get confused between CLL and SLL. And they are essentially, from a clinical standpoint, the same disease. But truly, biologically, there is something different about these two diseases, but we don't know what it is. If you look at these two cells under a microscope, or if you actually look at the features on the surface of the cell, something we call the phenotype, if you look at all of those things, these cells look the same, but for some reason, CLL is a blood-based disease, so it's typically high white count, maybe a little bit of adenopathy or lymph nodes, but not a lot. SLL is the other aspect. It's where you have a lot of lymph nodes and very little in the blood. We treat them essentially the same way. So a lot of times people will get confused about what they actually have. If you get told you have CLL, that's fine. If you get told you have SLL, that's fine. And if it's used interchangeably, that's also probably just fine. So CLL, excuse me, is the most common leukemia. It's the most common adult leukemia. And it's typically a disease of people who might be a little bit older. The median age is somewhere around 70 years old, meaning median saying that half of the patients are above 70 and half of the patients are below 70. And in fact, a fair number of patients can be below the age of 50, as of course I know many of people here today fill that bill. I have a patient who's 29 with CLL, so this does happen. Why this happens in patients, we don't really know. There are some environmental exposures that we know are related to CLL, but in general, what we have to tell patients is that the reason you got your CLL was just plain bad luck. We can't really say what exactly caused it. I wish we could, but in general, we know that it's not completely tied in individual cases to a specific predisposing agent. There are about 10% of patients who have a familial component to this. There is a family predisposition to CLL. Happens again in about 10% of all cases. But interestingly, if your disease is part of a family, it doesn't behave any differently than if it wasn't part of a family. And it's not treated any differently. And because of all of those things, we don't screen patients for it. So everybody's always wondering, well, is my brother going to get this or my children going to get this? The chances that they get it is extremely small, exquisitely small. It's not transferred through anything that we can do or actually control. There is true that there is a slight increase in a familial risk in patients, but it's very, very slight. And most people, despite the fact that they have a family member with the disease, will never get the disease. It's incredibly rare to see it in families and in general. So how do people present with this? Well, the vast majority of people now present feeling perfectly fine. Actually, the majority of people have no complaints. But there are times where you might have things like night sweats, maybe some fever, weight loss. Those are what we call B symptoms. Why do we call it B symptoms? Because we use the letter A to say you don't have symptoms, and we use the letter B to say you do. So that can happen, and those are drivers to get treatment sometimes. Sometimes the lymph nodes can get big, maybe the spleen. The spleen is just a big lymph node. Sometimes we can see involvement of the bone marrow that could lead to problems with other blood counts. So we might see people become anemic or have low platelets. That's something we call thrombocytopenic. It's not common, but it can lead to significant infections that happen over time. And rarely, I've seen CLL involving the skin, and it really can rarely involve all kinds of places, but in general, its presentation is in the lymph nodes and in the blood. And just having a high white count, it's very important to recognize that that's okay. That does not cause symptoms. So I have lots of people with white blood cell counts of 100,000, 200,000 that we are not treating because those people feel perfectly fine. High white count doesn't make you feel bad. Now, one of the things that we always want to think about when we're first assessing patients is what their stage is. And there's a couple of staging systems. We use a specific one in the United States for CLL known as the RISE staging system, and it's shown here on the slide. And I won't belabor this, but most everybody who presents presents with low or intermediate stage disease. In fact, really stage 0 or 1, meaning that they might have a little bit elevation in the white count and they may have some lymph nodes. It's very unusual to present with an enlarged spleen or anemia or thrombocytopenia, but that can happen in a smaller subset of patients. SLL is staged in a different way. It's staged by a lymphoma staging system we call the Ann Arbor system. One lymph node group above the diaphragm or one lymph node group below the diaphragm. Here it's shown above as stage 1. More than one unit, but essentially on the same side of the diaphragm as stage 2. If you have disease on both sides of the diaphragm, that's stage 3. And then if it's outside of lymph node groups, that's stage 4, so that could be involving the bone marrow. Most of the time, we're going to be staging with the RISE system and with assessing this as a CLL. So we stage patients. We also want to get some prognostication information for patients, and one of the major tests we use is called FISH. I think this is important for patients to understand and to know about. It stands for fluorescence in situ hybridization, where we can take cells, maybe from the blood, maybe from the bone marrow, maybe from lymph node tissue, and we can actually take a fluorescent marker or a probe, and we can look for certain things in the DNA of these cells. And what we look for are different chromosomes and the patterns of those different chromosomes. So we can have a marker that might be green that looks for chromosome 17, and we might have a marker that's red that might look for a different marker, a different part of chromosome 17. Same thing for 13, a variety of others. And this is the major way where we tell patients what their genetic profile of their tumor might look like. And that's very important because if we have certain features, we may treat the disease in a different way. We may watch some of these. Some we may not. Some we may treat more aggressively than others. And in particular, the one that we're always most interested in knowing about is a deletion of what we call the short arm of chromosome 17. That's called 17p or a 17p deletion. We also watch for 11q deletions that are important. And it turns out that some of these are actually favorable to have. A 13q deletion is actually the most favorable thing you can have, and it's actually even more favorable than having normal chromosomes. Why that is, we don't know. We also look at a variety of other factors that are very important. We look at what we call the mutational status of the immunoglobulin heavy chain variable region. So I won't say a lot about that, but to say that if your cells have become more mature, they're closer to that plasma cell, ready to make an antibody, they undergo a mutational status that's very important and very normal to generate a unique, specific antibody for that situation. That happens again in a more mature cell. That's a good thing to have if your CLL has that. If you don't have those mutations yet, it's a more immature cell and it's a higher prognostic disease. We look at other markers on the surface of the cell, CD38, ZAP70, something called beta-2 microglobulin, and all these factors play into our important decision making about how to treat, and in fact also to assess how patients are going to do with treatment. I won't say really too much about this part of the immunoglobulin heavy chain variable region mutational status, but just to say again, if you're a mutant, that means you've had mutations more than 2% of your cells. That's favorable. And if you're under that, it's actually less favorable. We've touched on CD38 and ZAP70, and you can see the cutoffs there of what we look at. And we also look, as I've said, at the chromosomes and are particularly paying attention to 17p, 11q. Some of those others are more favorable, as I've already mentioned. And this is, again, just that understanding. I think it's important to when people talk about this, to really understand what we're meaning about this rearrangement or mutational status of these immunoglobulin genes. So if you remember back to biology, these genes actually are rearranged so that we can create a very diverse repertoire of antibodies. And if that happens, it happens again in a more mature cell. That's what we call a somatic mutation. If your CLL cell has undergone that process, it's more favorable than if it hasn't. And this just shows you how people do with different chromosomal changes. And again, just to understand that this is very old data. We have a very rapidly evolving field. And because of that, this rapidly evolving field, the data is very lagging. And we don't really understand how survival is in 2016 with all these new treatments and how we're doing. But again, I wanted to reiterate that we pay very close attention to the cytogenetics, or what the chromosomes look like. So we've got our patient. They've come in. We've looked at their stage. We've looked at their prognostic information. What do we do to work them up? All these tests that we've already talked about. But sometimes we do some imaging studies, so CT scans might be important. And actually, sometimes we actually do something called a PET scan, which many people are very familiar with. So we've got all this data, and we then have to make a decision about what we're going to do. Are we going to even treat? And it turns out that in 2016, with all the things that we have, all these great drugs, we don't treat people unless there's a reason to treat them. So if you're completely asymptomatic and feeling well, where you're going to live a long time no matter what we do, we don't treat, we watch. And that can happen not only at the time of diagnosis, but once people get into remission. Sometimes we get people into remission, and they're going to be there for years, and we just watch. So what are the reasons to get treatment? Well, there's a variety of them, and you can see some of them here. Your lymph nodes are getting too big, your spleen's getting too big, it's starting to cause some pain, maybe it's making it difficult to eat full meals, maybe you're getting symptoms, you can become anemic, perhaps thrombocytopenic. All of these would be reasons then that we would say, you know, we probably ought to do some treatment. And that's where choosing the right treatment is critically important for understanding how people are going to do. And so let's talk a little about treatments and how we do this. And they come into some big flavors now. Of course, not that long ago, we used to just have chemotherapies, and we still have them, obviously, but that's all we had. So there are drugs like fludarabine, bendamustine, chlorambucil. We'll touch on some of those. Quite a while ago, we developed an antibody called rituximab. Maybe about 20 years ago, that antibody, the first antibody ever approved for cancer treatment, has now led to a variety of other antibodies that are approved, and some that aren't even on the list, and many, many that are in development. They've been game changers for how we treat this disease. And I know many people here in the room or who are watching have received antibody treatments, and probably rituximab most often. We have a variety of targeted treatments, and that's really where the excitement is now. So we're going to talk about ibrutinib, touch on idelalisib. a new drug just recently approved about 2 weeks ago, maybe less, known as venetoclax. It also was previously known as ABT-199. And there's many in the pipeline and development that are surely going to get to the clinic for widespread use, now only in clinical trials, but very exciting time for targeted treatments. Let's just say a word about targeted treatments with regard to antibodies. So antibodies are a way to actually help our own immune system recognize the cancer. So we can make antibodies, of course, to fight infections. We can also make antibodies in the laboratory to fight a cancer cell. So we can do that. That's an antibody that's typically made to target something on the surface of the B lymphocyte or the CLL cell. And when that happens, when the antibody is delivered to the patient, it finds the cell, and the way it does that has a specific parking spot. So the antibody won't park just anywhere, it'll only park in the specific spot where it will fit. So as an example, rituximab, its parking spot is called CD20. So if it's not CD20 parking spot, that rituximab just drives on by and finds the next parking spot where it can fit. And when it does a few things. When it parks there, it can actually kill the cell directly. It also can impart what we call effector cells or immune system cells to come into contact with the CLL cell and kill the CLL cell. And a variety of other mechanisms with regard to the immune system that are very valuable. So we target CD20, we can kill the cells directly, and we can actually recruit the immune system to kill the CLL cell through the antibody. And we've learned that we can actually make antibodies more efficient by making them more human or human-like or humanized. And that's through genetic engineering. We can actually take antibodies now that are fully humanized that have much greater potential to kill the CLL cell and control the disease. So we know that there's things like ofatumumab, rituximab, obinutuzumab, and a variety of others that are, again, in development. So what do we do as a standard treatment? Let's say we have a young patient who's very fit, no high-risk features. Well, this is what we have been doing for many years, decades, delivering what we call chemoimmunotherapy. The chemo, of course, is drugs like fludarabine, bendamustine, rarely in these days pendastatin, and the immuno part or the immunotherapy part is the antibody. So it might be rituximab or it might be something like obinutuzumab. And that actually data has been incredibly important for controlling disease and taking care of patients. The Germans did a major study looking at upfront treatment of CLL in the CLL-10 study, comparing these regimens, many of them over the years. And this trial that they recently did compared the regimen of FCR to BR. All of those doses there and everything aren't necessarily important, except to say this is a trial that would be for someone who could tolerate or wanted to get chemotherapy. And what was found from this trial is that the complete remission rates were quite encouraging. At least half of patients would have complete remissions. The overall response rates were almost 100%, and people could do very well from that standpoint. But the toxicities could be significant. And in particular, what those toxicities are things like myelosuppression or lowering of blood counts and the risk for infections. And so those are things that we want to avoid. And that's why we're looking now to thinking about how we would treat patients who might not want to get chemotherapy. And I'll say a little bit more about that in a second. What about people who are less fit or perhaps a little bit older? Well, we think about more milder treatments, at least we have in the past. So those have been things like lower doses of chemotherapy like bendamustine and rituxan, and a variety of antibodies. And this is just a partial list of what we could do. More recently, the German Lymphoma CLL Study Group has pioneered another approach for older patients, might not be particularly fit, using a regimen called chlorambucil and obinutuzumab. This was a randomized trial comparing the standard chemotherapy chlorambucil by itself to a regimen of the antibody with chlorambucil, and that antibody could either be obinutuzumab, the fully human antibody, or the first generation antibody rituxan. And essentially what was seen is that this antibody obinutuzumab was a game changer in older patients. It had a significant improvement in addition to chlorambucil from a response rate, compared to rituximab, and patients have done very well. So now this is a standard approach, still using chemotherapy, but I should have said that the chlorambucil is an oral pill, and it's very, very well tolerated, and it's something we can do in people who are considerably older. And in the sake of time, I won't say a whole lot about this, but if we compared the time to when the disease would come back, it was greater, significantly greater if we used the new improved antibody, obinutuzumab, compared to rituximab. So the idea here is just to show that we're making significant improvements and continue to do that. Let's just talk in the last several minutes here about targeted treatments that are not antibodies. These are all these new exciting drugs, and I put just a handful of them here on this slide. So we know a lot about idelalisib to this point. We also are very familiar with ibrutinib. We've talked a little about the antibodies, but we'll also touch on venetoclax. And all of these agents target specific enzymes that are key to the production of the life of the CLL cell. So in general, CLL is a problem in two ways. We're making too many abnormal cells, and they're not dying. So if we can actually throw something inside the cell that interrupts the normal function of proliferation and not dying, we can actually induce those cells to undergo cell death, and that's how we control the disease. So what are our goals of these novel treatments? Well, we want to, of course, improve therapies. We want to be able to do it by targeting exactly where we want to go, and we want to do it by not targeting the healthy normal cells. That reduces side effects. We want to actually make the immune system stronger, and we want to actually lead to cures. And actually, when people say, oh, we're not going to cure CLL, I don't believe that. We actually do cure CLL. We've been doing that for a long time. Unfortunately, it's only been with allogeneic stem cell transplants, which is kind of the ultimate immune system resetting. But we are now figuring out ways to get the immune system to help us do it without a transplant. So we can cure this disease. We're working towards it, and we hopefully will do that sometime in my career. I hope so. So now the big question is, since we have all of these things, should we even be doing chemotherapy anymore? And should these single agents actually be replacing chemotherapy? So let's talk about some of the data suggesting that that's a reasonable thought. Ibrutinib is a new oral pill. It's been around for now a couple of years. It's an inhibitor of an enzyme known as BTK. It stands for Bruton's tyrosine kinase. And you can just see from the cartoon here that if you interrupt this pathway and interrupt the signal that's going to the nucleus of the cell that's driving the survival of that CLL cell, that we can actually cause that CLL cell to die. And we did a trial, and I'm not sure if anybody in this room participated in it, but we had lots of people on this trial where we randomized upfront patients who might be, they were described as people who we didn't want to give chemotherapy to over the age of 65, to ibrutinib or to that standard chemotherapy chlorambucil. And what you can see is that on the ibrutinib side, 90% of patients had a response, whereas only 30% or so of patients had a response to the chemotherapy. Dramatic improvement. And if you look at how long people did before they progressed, in other words, when they stayed in remission, you can see that the ibrutinib arm was vastly superior. There was about an 80% reduction in your risk of progressing if you got ibrutinib compared to the chlorambucil. At 2 years, 90% of patients still are on the drug and had not relapsed and had not had a side effect. That's without chemotherapy. It's an incredible advance for what we're doing. And if you look at overall survival, how these people do, not surprisingly, people are going to live a long time no matter what, but everybody's alive doing well on this kind of agent in this patient population. And this is also a drug that we use commonly in the relapse setting. And this is what led us to understand that this was important in the relapse setting, where we compared it to just antibody treatment. Hopefully I'm not confusing anybody, but I think this data is important to understand why we're doing these things. Now, we use these agents, and we use these agents quite effectively, and we need to know how to manage them. One of the things that many people are familiar with here who have had ibrutinib or maybe had idelalisib as an example is that the absolute lymphocyte count will go up over time and may stay up for a long time before it comes down. When that happens, that's normal. Don't be alarmed. That doesn't mean the drug's not working. It's just one of the things that happens with the drugs. What happens is that these CLL cells, as they're starting to be killed, they get mobilized out of the lymph nodes and they circulate in the blood. So the white count will go up for a significant period of time. But the lymph nodes on the right, what we call the sum of the product diameter of the lymph nodes, how much volume of lymph nodes there are, can go down and can go down very, very quickly. I've had people who have gotten ibrutinib where within a few days I can tell their lymph nodes are dramatically smaller. And here's an example. This is a patient that was before with 11q deletion, and you can see 4 weeks later after being on ibrutinib, a dramatic improvement. Well, who benefits? Well, it turns out that really everybody benefits, even the highest risk patients. I won't go through this whole slide, but this is something we call a forest plot. Why do we call it that? Because that line in the center, that vertical black line, is the trunk of the tree, and all the branches go out. And if the branches go to the left, it says that ibrutinib was better. If they go to the right, it's the ofatumumab, which was the control in this study. And the important thing is to say that even if you were older, you could do just as well as younger. Even if you had high-risk cytogenetics, meaning 17p, all those things, you could have a dramatic improvement with the drug. So we're making major strides there, and in particular for 17p. For 17p, this is proven to us to be a very difficult treatment, thing to treat, and ibrutinib has been revolutionary and a game changer. Not just ibrutinib, but all of these drugs. I've had people on this drug and others for over 4 or 5 years with 17p deletions who have never relapsed. That never happened with chemotherapy. We would be talking about transplants for those patients. Okay, I'm not going to say too much about side effects, but to say none of this is free. Of course, there's always potential side effects, but they're usually very, very mild and very, very manageable if you have them. They can be like some muscle aches or joint pains, maybe a little bit of mild diarrhea, a rash, all things that we commonly see and are very familiar with how to manage. Except it's very important for me to say one thing. If you're ever on one of these drugs, it's very important that you inform your doctor whenever something's going on. It always should be blamed on the drug. It's not because you don't have diarrhea because you ate something bad at the restaurant the night before. No, until we prove otherwise, these things are due to the drug, and that's very important for you and then, of course, the doctor to know about. I won't say a lot about idelalisib at this point, but it's another great drug. We did a very important trial using it in combination with rituximab compared to rituximab alone. We saw dramatic improvement in the patients who got the idelalisib with the rituximab versus the rituximab alone for keeping disease away. And the same thing happens with this drug. White count can go up, that's in the blue line. The lymph nodes can come down, that's in the orange line. We know the responses are excellent and the lymph nodes get smaller dramatically. And here's an example of those types of things that we can see with idelalisib. Before treatment and after treatment, lymph nodes dramatically improved. This is with just a few weeks of treatment. And again, looking at a forest plot, dramatic improvements in all these different subgroups. Important to say that even for 17p deletions, very bad risk patients, we can do very well. Now this drug, as all drugs, they have a unique side effect profile. So we always want to watch for this. Again, watching for issues that can develop are very important. So anytime you start on one of these drugs, it's very, very, very important to be educated about what the side effect profile really is for that drug. I want to just say a word about a new drug called venetoclax, a dramatic, another game changer that most people will experience at some point. This is a drug that targets a protein inside the cell called BCL2. BCL2 is an overexpressed protein in CLL cells that inhibit the ability of those cells to actually die. So if we can interrupt BCL2, take away that signal that's making these CLL cells live, then those cells will die. And that's how this drug works. And in fact, in very, very heavily pretreated refractory patients, we're getting response rates of more than 8 out of 10, even in the highest risk patients. Many of those are complete remissions, and those people can do very well. And in fact, this data led to, as all this data has led to multiple publications, but this was recently published in New England Journal of Medicine, and led to its approval for patients with relapsed disease. You'll hear more about venetoclax, its side effects, and how to manage it. Again, it's not for everybody, but when the time's right, it's a dramatic drug. So coming back towards the end here, what should we be doing from chemotherapy? Should we be getting away from it? It's very controversial. Many experts might say that they still give chemotherapy, and others would say that chemotherapy is already dead. In fact, the father of FCR, Michael Keating, is now even telling people that he thinks FCR won't be given at all, or at least very much in the near future. FCR still has a role, though. It has a role in certain situations, and in particular in the most favorable patients. And that's showing here that now if you're out more than 12, 14 years, there are some people who got FCR who have never relapsed. It's somewhere around 25% of patients. So if you're a young patient and you want to get chemotherapy and you have some of those very favorable risk features, you might do well. It turns out, though, my personal opinion about that is that those people are going to do well no matter what you do. They have the most favorable disease, they're going to do well, and I think we'll find out over time if we're going to even be doing chemotherapy for those patients. Okay, I'm just going to close by saying a little bit about some of the more important things of transformation of where we're going. Really, this has been a paradigm shift in oncology and in particular in CLL. We're not relying on chemotherapy, as I've said. We're relying on the immune system, and we've started to figure out that those kinds of approaches are what cure people. Really, this is a paradigm shift in understanding how we approach patients. So using the word cure for CLL is relevant. It's important, and I totally support it. And we've done all these things looking at cancer immunotherapies, and I want to just spend a few minutes talking at the end here in the last minute about CAR T-cell therapy that everybody hears a lot about. This is a dramatic game changer as well that will take patients who maybe have run out of options and give them a chance for long-term survival without having to undergo an allogeneic stem cell transplant. Essentially what we do for these patients is we collect their own T cells, immune system fighting cells. We take them to the laboratory. In the laboratory, we engineer them. We engineer them to actually have a marker on the surface of the cell that's made to target the CLL cell. The problem has been is that our immune system, if we get CLL, has ignored the fact that we have a cancer cell there. And it's essentially, cancer has escaped surveillance of the immune system. So what we need to do is re-educate the immune system to fight the cancer and to recognize the cancer. So we take the T cell, we engineer into it a marker that will be made and expressed on the surface of the cell to target the CLL cells, re-educate those T cells to fight the disease. So we do that in the lab, and then we come back after we've multiplied those cells into the millions and redeliver the patient's own cells that are now engineered to target CLL back into the patient. So does it work? It absolutely can work. Here's a patient on the left with lots of lymph nodes in the neck before some chemotherapy. That was called rice. In the middle, after the rice, there was no change, so the patient went on to get chimeric antigen receptor T cells, and then very quickly, 1 month later, all of those lymph nodes are gone. This can happen. This is a patient who had had prior autologous transplantation. This is a large mass of lymph nodes in the abdomen. 27 days after getting CAR T cells, this has completely gone away. So lots of exciting new approaches, and I think we're only scratching the surface of where we're going with CLL therapy, but it's completely evolving away from chemotherapy. It's not your father's CLL anymore, and I would encourage everybody to think about participating in clinical trials if you have that opportunity, because all of the things we've talked about here evolved out of clinical trials, and all of the exciting new next generation drugs that are improvements over what I've already shown you are in clinical trials today. And I appreciate all of that. So think about these recent advances, making wise choices about what the treatment goals are, taking into account what quality of life issues might be, and thinking about some of these more exciting new agents that are in clinical trials. And I think that's where I'll finish up. I want everybody to know that I have an email here. I'm always welcome to be contacted through email if you have questions at any time. And I appreciate everybody's opportunity to spend some time with us today, and thank you very much.
So I should have clarified that we prefer if people can write down any questions you have. I think either Laura or Denise will be happy to take those, and I'll try to sort through them. And also we may have questions that they're trying to collect for us from online. As you gather any thoughts that you may have, I'd just like to start with a question of one of the issues that it seems to me would be the art of judgment here is that you don't always have one problem in a vacuum, and you have potentially competing medical problems, and you're looking at a trajectory of a disease that may be a long time, and you don't necessarily want to incur any greater toxicities than you need to manage the problem for whether it's years or a decade or more. So, how do you factor in whether to go full tilt? You'd mentioned FCR as a regimen that can be intensive, maybe has a higher leveling point at the end, but if people may have other medical problems or just at a certain age, whether it is 10, 15, 20 years or 30 years may be less of a concern, right, especially if you have to trade short-term side effects for long-term questionable benefit.
Right, so it's an incredibly important question, and essentially that's the most important thing we could be talking about here. I think a big part of that decision-making process revolves around a relationship between the doctor and the patient. Understanding what the patient's goals are, and also having some experience in those kinds of settings. So the most important way to achieve that kind of relationship is for the patient to be their own advocate. No one's a better advocate than you as a patient. So you need to, I would encourage any patient to always make sure that the doctor's listening. We don't always do the best job of that. We need to listen to patients. We need to know what your goals are, and we need to take that into account with how much risk a patient is willing to take. So in general, I tell my patients, listen, you have lots of treatment choices. And they go from very, very conservative approaches to very aggressive approaches. Some of them may not be appropriate for you, but in general, it comes down to what kind of patient you might be and what kind of risk you're willing to take. So perhaps an older patient might be willing to wanting to take less risk, meaning less risk of having to end up in the hospital with a side effect such as an infection, with the idea that they may not have as long a remission as somebody who might take a more risky approach, risky meaning a higher chance of having, as an example, an infection, but their disease may stay away a lot longer and they may hit that home run. In general, that's a conversation that you can have almost all the time. And where that comes into figuring that out is that relationship, understanding the doctor, understanding the patient, and what's right for each individual case. And I think everybody has a different philosophy, and we have to listen and spend some time trying to figure that out.
I think it's quite complex when it's great to have options,
Yeah.
but there's a lot of ways to play your hand.
Let me just say a word about that. This is not your father's CLL in that this has become such a specialized field. I haven't told you all about the genetic mutations that we're learning about that are leading to specific drugs for specific targets for one mutation that wouldn't be an agent we would use for another mutation. This is pretty complex, and understanding these drugs and in particular the side effect profiles of these drugs is very important. So in making sure that you're on the same page with your doctor about those things and your doctor's on the same page with you about those things is very important. And how you establish that relationship with mutual trust and understanding is unique to each individual patient, I think.
it seems to me, medicine has changed over the last 20 years, and it used to be more paternalistic. You say, here's what you should do, or here's what I think you should do. Now there's more of a I think very favorable tendency to present options, but I don't think it necessarily abrogates your injecting an opinion in there of judgment, but just the balance is not saying what somebody needs to do, but not just dumping it in their lap and saying good luck with that and let me know what you've decided.
And I think CLL is a very interesting disease because more often than not, no matter what we choose to do, a patient's going to do well for a long period of time. So it's really, in many cases, and particularly for, let's say, for an older patient, we're just palliating to control the disease and get people to living to 85 years old, and maybe they're going to have some other complication. Unfortunately, we're all going to, die of something. We know that, but hopefully, what we're learning is that in CLL, it's really a management situation that requires us not to cause too many problems and to allow people to live for a long period of time.
So just to make sure the treatment's not worse than the disease.
Treatment cannot be, especially in this day and age, the treatment should not be worse than the disease, absolutely.
We'll start with the question of how much of a concern is it to interrupt treatment? How is that a dreaded problem? Is that just, well, you deal with that and don't hesitate either because of low counts or some intercurrent
it's a good question.
Infections or complications?
Yeah, it's a good question. For most patients, I should first say that for most of these drugs that we've talked about, the only data that we have is using them indefinitely. In other words, using them until there's either disease that's growing again or there was some side effect that would make us stop treatment. The only reason we do it that way is because we have no data any other way. But the truth is we're learning, and we have trials now that are ongoing where we're taking patients, getting them to a good remission and stopping treatment. So in general, that's a safe strategy, but only do it in a real thought out way in conjunction with your doctor. Let me say that what we really want to do is learn about when to stop treatment in some patients. So the classic example is chronic myeloid leukemia, CML, where we have many now agents that are oral pills. We've had them for 20 years that have essentially were game changers for CML. And the first one that was ever approved was a drug you might have heard of called Gleevec, where people would take this pill every single day. And they were told that they had to continue it forever, the rest of their lives. Well, now we have people that are out 15 years, 20 years, have never had their disease come back, and we're learning that they can stop the drug and their disease is not coming back at all. So we're way too soon in CLL to know exactly what we're supposed to do here. There are cases where you can stop treatment, but you shouldn't do it without a well thought out strategic plan.
Okay. A couple of questions about clinical trials. One issue is that I believe in CLL or in general in cancer trials, the participation in clinical trials among patients out there is low. It's in the range of 3%. Why is that so low? What are the barriers? Is it any sense of, are these trials too stringent? Are they not available to enough patients geographically? What's the holdup?
Yeah, so it's all of the above, unfortunately. I will just make a plug for clinical trials. Most people who know me know I'm a big fan of that. And the reason is that you have an opportunity in oncology to get something better than what we call the standard of care. The standard of care might be perfectly appropriate and often is, but in general, what we're offering in clinical trials in oncology is a chance to get something better. We don't compare to placebo as an example. Oftentimes people might say, listen, I don't want to be a part of an experimental program. I want, that scares me. It turns out in oncology that would be unethical to expose somebody to something that we didn't think had good chance or promise to help them. We don't always achieve that, but more often than not, and especially in CLL, we do. So I think it's a little bit of an issue about education, about what clinical trials are, how they're done. Remember, as I said earlier, no matter what drug you're getting today, it was in a clinical trial at one point. So if you got ibrutinib, you were the very first person to get ibrutinib on the very first in human clinical trial, you were pretty darn lucky because at that time the only option you had was FCR or BR, and that was an early phase clinical trial. I know people in this room who are on early phase trials who are doing very well. Not always the case, but it gives you a chance to really actually hopefully provide some long-term benefit. So it's about education. And one of the other things that's important is that you need to ask your doctor. The patient needs to be educated to know that clinical trials exist or to want to find out about clinical trials if that's your goal. So your doctor may not have a trial for you, but somebody across town might have a trial for you that you might like. So you need to be the advocate to find that out if that's something you want to do. Sometimes it may be across the country, and that might not be something you'd want to do, but it doesn't hurt to know about these things. So it's education and exposure in large part.
To clarify, there can be placebo-controlled
Yes.
trials, but only in situations where the alternative of not being on any treatment at that time, active treatment, would be a very fair consideration.
Absolutely.
Like very late treatment
Absolutely.
or as a maintenance after completing it, and we
Right.
just don't know if more is better.
Right,
And
right,
importantly,
right.
sometimes placebo-controlled trials show us
Right.
that the placebo arm is better, and that we were wise to ask first before presuming more was better.
Absolutely. I will just say, Jack, just along that line, that that's a very true statement, and I didn't mean to say that we don't occasionally use placebos, but in CLL, interestingly, we don't commonly do that. That's done a lot more, I think, in other cancers. It's rare in CLL.
Right. Well, I mean, it's never going to replace a setting where there's a good alternative
Right.
active therapy.
That's exactly right.
What about the question of, somebody asked, why are so many of these trials only in patients who have already been on and progressed through several lines of therapy? Where are the trials for early, even treatment-naive patients?
No, it's such an important question. It's one of the flaws of how we do this. What we want to do, and the most important thing that we want to do when we treat somebody with any drug, whether it's part of a trial or not, is we don't want to hurt people, right? The last thing we want to do is cause more problems than you already have. So because of that, we tend to reserve early use of an investigational agent for people who may have very few options and maybe need to take that and are willing to take a little more risk because of the unknown. But that doesn't help the person in the upfront setting as well, and it turns out by the time it gets to the upfront setting, that patient's now in the relapse setting. So it's a flaw of how we do this, unfortunately, and we need to do better at that. And it's why we always tell patients we don't treat you until we have a reason to treat you. So if I'm telling people we can cure you, most likely someday, or at least I believe that, I hope we can, why is it that I don't want to treat you when you're first diagnosed? You feel perfectly fine, your white count's low. Why is that? It's because we've never done studies of significance to address that. And in CLL, it's particularly problematic because if you're 70 years old, you're diagnosed with CLL, you feel perfectly fine, you have a low burden of disease, you're going to live 15 or 20 years no matter what I do. So for me to give you something that's hopefully going to hit a big home run and accrue the risk of having a problem is not very appealing. So it's something we have to figure out, and I wish we did a better job at it.
What about the patterns of resistance? How often does a patient whose cancer progresses through first and second line therapy ever benefit from third line therapy? Mm-hmm. Is there
Great question.
enough cross resistance that there's a real value in
Great question.
later, later lines of treatment, or
No question.
is it a responders respond disease, biology specific issue?
Well, no, this is totally different. I should have said a lot about this as we were giving the presentation. All of these drugs that we're talking about here have different mechanisms of how they kill the CLL cell. So the biggest problem that we used to have was that all we had was chemotherapy, and chemotherapy in general is chemotherapy. They may be different classes of drugs, but once you become resistant, or I should say refractory to one class of chemotherapy, if you nominally change to a different class of chemotherapy, you don't do particularly well still. Now that's a different story. So if you become refractory to one type of treatment and you change the class to a different mechanism of killing cells, maybe you've gone from BTK inhibition with ibrutinib, and then that you've become resistant to that and you've switched to BCL2 inhibition with venetoclax, you can have dramatic, amazing responses, and that can go on for 3, 4, 5, 6 lines of treatment, maybe even longer. And so that's, again, part of the reason this isn't your father's CLL, I guess.
So this is really, it's not like you only get one or
Nope.
two shots on goal.
No.
These are all different angles.
That's right. And just because you may have had some difficulty with the first or your most recent treatment doesn't mean you're going to have that with the next line. I'll just say, I have a patient who had a 17p deletion. I saw this patient for the first time to consider an allogeneic stem cell transplant over 4 years ago, high-risk disease, 17p. She's been on one of these drugs we've talked about for over 4 years in a remission. That's unheard of.
Wonderful. So a question came in. The treatments we're talking about are, of course, on mutant B cells, and but is there any way to screen, identify early, or have any prevention role for this? So you're actually detecting the disease before it's florid disease.
It's a great question. So the answer to that is, so far, no. But the only reason the answer to that is no is because we've never looked, believe it or not. So now, actually, we're just embarking on, in CLL, a trial, a fascinating trial, where we're taking well patients and we're actually figuring out at the genetic level why they're developing cancer. And so from that, we're going to be able to take patients and we're going to be able to determine what keeps people well and how do we prevent developing the disease. Not just that, we have a trial that we're just actually getting going where we're taking patients with CLL and we're getting them to a remission, and then we're actually sequencing their DNA, we're actually looking at their proteins, doing very sophisticated tests to predict and determine if they're going to relapse and when they're going to relapse. And so when we have all that data, we'll actually be able to hopefully work towards preventing the disease as opposed to treating it. Unfortunately, we're several years off from that, but it's definitely on the horizon.
The next frontier.
Very cool.
Another person asks about skin symptoms, skin involvement, how often and how does that manifest itself?
It's very unusual to have leukemic involvement of the skin, but it can definitely happen. I've seen it many times, but of course I see lots of CLL, but it can essentially look like a rash, and in general it's kind of a nodular rash that doesn't go away. It actually can be little nodules that can be a little bit tender. Tenderness is usually not cancer, but in the skin it is because you're starting to stretch that skin and it can feel a little tender. It's very unusual. I mean, I will say the chance of getting skin involvement with your CLL is less than 1%. It's very unusual.
I'll ask again if anybody online or in the room has any questions. I wanted to follow up on one issue that you raised, and that is this, as much as you presented here, you have to be selective about what you present, and there's layers of complexity below this. Of course, this is something where many of us who do not do hematologic malignancies don't treat this. But in many parts of the world, it's a general oncologist treating everything. How important is it? I mean, as diplomatically as you can be, but still, truthfully, what is an incremental benefit? Is it critical to have a very focused heme malignancy specialist somewhere in the mix?
Good question. I can only give opinion to that. What I would say is, again, one of the things I would say is that the best advocate for you is yourself. And I would also say that means that for you, you may feel comfortable without having that kind of specialist, and others may feel that they absolutely want someone like that, and others might be in between, where they have their general oncologist and they see this specialist person every once in a while. My general feeling of that is that first off, it never ever hurts to get a second opinion. Not just one time. You can get a second opinion every time you need more treatment. I think that's always a good thing. But it's only always a good thing if that's what's valuable to you. In general, I think it is usually very valuable. The other thing I will say is that experts or specialists have access to some other things. So it's always good to understand what kind of clinical trials they have and to actually get an understanding of what the therapies are that if I was going to treat somebody with ibrutinib and their community oncologist was going to treat them with ibrutinib, we both say the same thing, but I might be able to give a little more pointers or insight into what the side effects might look like, what to anticipate, and maybe what to think about next or those kinds of things. So I think in general it's never a bad thing. I don't think everybody needs a specialist. Those people really probably play much more of a role when disease is more refractory and has progressed multiple times.
Right, good. Okay. Well, if there are not other questions that are coming in, either in the room or from outside, let me thank everyone. I'll start with those folks here in the room for taking the time, and it's a really good energy, and I think it really, even though there's a lot of people we know are going to get a lot of value from this, who we don't see. It's hard to just speak to a camera, and it's really helpful to have just the connection with
Absolutely.
people. So thank you for being here. I hope it's been worthwhile. I want to thank Grace for putting this on. I also want to thank Infinity Pharmaceuticals, Genentech, and Biogen IDEC for supporting us, but of course, especially John for taking the time out to create this very good summary that is going to help a lot of people both in this room and far outside. It's exciting times.
Thank you, Jack. Great. Thank you for having me.